And I think we are live. So hi everybody and welcome. Thank you so much for joining us this afternoon. I'm really looking forward to having a good chat with Lynda Sibson. First of all, I'm Zoe. I'm Dr. Zoe Williams. I'm a GP and I work with Visionable. Lynda, would you like to tell us who you are?
Yeah, hi Zoe, hi everyone. So my name's Lynda Sibson. I'm by clinical background, I'm a primary care nurse practitioner, but I currently manage the out-of-hours stroke telemedicine service across the east of England, and we've been using Visionable for 10 years to support our stroke patients.
And we're going to get into that. I want to ask you all about the East of England and how you've been using Visionable and the impact that's had on outcomes. But just for everybody's sake, this is kind of to delve a bit deeper into the presentation that you gave earlier, which was a digital health webinar all about how utilising Visionable and video technology has enabled you to improve the acute stroke service in the East of England. So could you give us just a very brief overview, I guess, for people who weren't able to attend that webinar, what that was about, and just I guess the top line detail and info.
Yeah, so we've been using Visionable and we've part of the Stroke Telemedicine Partnership since 2010 actually. So we're into our 11th year. And it really came about because there is really a lack of stroke consultants across the UK. We know about 40% of our stroke units have unfilled posts, so it's quite an issue across the region. And we know that we need stroke consultants' expertise if we're going to thrombolyse a patient presenting with an acute ischemic stroke. And these represent 85% of all presenting stroke patients. So the majority of patients that present will present with a blood clot that's causing their stroke. And they have a potential to be thrombolyzed, so a clot busting drug, and we use alteplase to dissolve that clot. And we need to give it within a certain period of time. So we often talk about, and we've seen the adverts on television about FAST, the face, arm, speech, when to phone for help. And it's about actually time is brain, so that the more quickly we can restore the blood supply to the brain that's been affected by the blockage, the better the outcomes for the patients. So back in sort of end of 2009, 2010, we found out that actually we were only thrombolizing, so giving our clot busting drug, to about 1% of our patients. And the reason it was quite low was because we were having to move patients between hospitals to get the drug. There was only 2 hospitals in the region that gave the drug. And we only had 3 hours at that stage from symptom onset to when we gave the first dose of the drug. So many patients, by the time they got to the second hospital, were actually out of time. So that wasn't great. And we know that if we don't treat those patients quickly, there can be profound, disability, physical, mental, it has emotional effects. There's effects on health and social care that the patients require. So there was a collaborative approach between the hospitals across the region, initially 4, and now we've got 7 hospitals. And basically in an out of hours situation, so on a weekday, it's from 5 p.m. to 8 a.m. and then 24 hours over bank holiday and weekends, we have 1 stroke consultant who is available for our 7 hospitals. And we use Visionable as a video conferencing system to link with those hospitals to provide a virtual stroke consultant when a patient presents with stroke thrombolysis. So we bring the stroke consultant to the patient rather than moving the patient around, which is much better for the patient. And since we've been doing this, the license for alteplase has increased to 4.5 hours. So we've got a little bit longer, but we still give it as quickly as we can. And there was an upper age limit of 80, so we couldn't treat patients over the age of 80, which we now can. And so that meant that we've been able to thrombolyse far more patients than we could have done previously. So we currently have 14 stroke consultants on our rota, all expert senior clinicians, and they provide care for 7 of our hospitals. And it's been very effective. So out of the patients that present to us, this isn't across the region, it's just telemedicine patients, we now thrombolyse about 40 to 43% of them. So we've been able to increase that. I think across the region, with all patients, we're about looking at 10-12%, which is gradually increasing. So we've been able to bring care much earlier in the stroke pathway, which we know improves stroke outcomes. And we've also had a recent health economic review by the University of East Anglia, And it found that not only were we clinically effective, we were helped to reduce the length of time someone spent in hospital, but we were also very cost effective. And I think they estimated, if memory serves correct, for average, most hospitals, we save them about £450,000 a year in costs alone. So it's not only clinically effective, but it's also cost effective for the trusts.
Well, it's a really good example of when we can utilise technology, when rather than replacing something, it's creating something new. So that, we talk about percentages quite a lot, I think, in healthcare, but it's even people who were coming from a background outside of healthcare to go from 1% of patients who were able to receive this brain-saving treatment, thrombolysis, so that area of the brain that's being affected, you can dissolve the clot in time for that brain to still function versus not. For it to go from 1% to over 40%, that's mega. That's huge. What sort of numbers of patients are we looking at there?
So since we've started in 2010, November 2010, we've assessed nearly 4,500 patients. So that's gradually increased year on year. So last year, despite seeing dips with the COVID sort of lockdowns, we've actually was our busiest year. So we saw 520 patients last year in general. So we average about, I guess, 40 to 50 patients a month of those patients that are presenting. And it's not just the patients that we thrombolyse, of course. There's patients, so 57% we don't thrombolyse. And the most common reason for that is still that those patients are outside that 4.5 hour time range, that it's safe to thrombolyse. So we have a sort of regionally agreed, we managed to get all the doctors to agree to one pathway, which was a bit of a miracle in itself. But it was sort of based, and it's very slightly, the patients remain the clinical responsibility of the trust that they're with, but so we're just bringing in kind of that expert advice. So we have a kind of a traffic light system, so patients that can definitely have it, they're over 18, they've got acute neurological symptoms that are still there, they don't have any sort of underlying conditions or any bleeding issues that we can't thrombolyse. But most commonly they're still presenting over 4.5 hours. And it was quite interesting. So we had a look at the numbers of patients and why it's taking so long. And it still seems that patients are taking quite a long time to phone for the ambulance. So that's quite interesting. And I guess the numbers are relatively small. It's clearly all these numbers are looking at our service alone. But I know that during at the beginning of March last year, we saw a big drop off in patients coming to our service, being referred. And actually, when we spoke to the hospitals, they said overall stroke and patients having heart attacks dropped off dramatically. And I think there was a sense, and certainly when we spoke to our ambulance service colleagues, that people didn't want to bother the health service. And I expect you found that in your clinical practice. It's like people didn't, oh gosh, I won't bother them. And also an additional with hospitals, I don't want to catch COVID. I might, this is where all the patients are. But the tail end of that is we're now seeing quite a lot, I suspect, of physical disability of patients who we potentially could have treated, who unfortunately will have remained disabled, which is a real shame. So there's still, I think, a public health message to get out there in terms of, if you see any of the symptoms of face, arm, speech, you need to phone, quickly and start that kind of that time is brain thing. We need to see you really quickly, just phone and let us get you help. But it was quite interesting, just as an aside, we were talking to one of the paramedics, because we're doing a study project with our paramedics, as you know, perhaps talk about in a minute. And he was saying it's quite interesting when you speak to patients and ask them why they've taken so long to phone. He said they sometimes say, and this isn't all of them, they think they have to have all of them. So they think they have to have face, speech and arm. So they don't realise that actually any one of those is really important. So that's about public health awareness, isn't it? And about getting that message out there about any one of those symptoms. Please call us, we will come to you.
Yeah, I know the same has been true with COVID, actually. I've had patients where they said, I've got a cough, but I haven't lost my sense of smell. It can't be COVID. It's like, no, any of them. It's interesting. And certainly I know my role in the media last year at one point, it really was about encouraging people to come forward straight away. If you do have symptoms, it could be a stroke, it could be a heart attack, it could be cancer. Please don't sit at home and sit and wait and see if it's going to get better, because minutes make a big difference.
Absolutely.
In the east of England where you are, I mean, I live and work in London. So we are very lucky in that, there's always a hospital. If you're in an ambulance, there's a hospital within 10 minutes, pretty much where you are. But could you sort of talk about perhaps some of the additional challenges that you face in the east of England?
Yeah, so the east of England's a lovely part of the world, but it's quite rural for a lot of it. And one of the issues we also had when we looked at the data before we started the service was that particularly in North Norfolk, we have quite long ambulance run times, sometimes of 45 to 60 minutes. So to get a patient from their home into the hospital. And then on top of that, we have what we like to call the tractor factor, in that we have quite a lot of rural roads that aren't fantastic. They're single, they're lane A roads. There's not a lot of dual carriageway.
So you actually get a tractor on there that you're stuck behind. You're stuck behind it. Wow.
You're stuck behind it. It's stuck behind it. I mean, obviously they're pretty good and they move out of the way. And there's if anyone knows Norfolk fairly well, there's one of the main roads through Thetford is now dual carriageway the whole way up to Norwich. So things are better than they used to be. But certainly for moving some of our patients round when we're looking at some of the other treatments for bigger strokes like thrombectomy, where mechanical extraction of a very large clot is. So I was talking to one of my colleagues who works at James Paget Hospital, which sits right on the coast. And she said they actually use the air ambulance to get the patients from Great Yarmouth all the way down to London for treatment, because it's just so much quicker than a land ambulance, because we've only got 6 hours. Time is really upon us. So
to go from Great Yarmouth all the way to London.
Yes, right. Yeah, particularly if they've been late in presenting. So even if you've thrombolyzed somebody within an hour or two, you've got 6 hours from presentation to what they call puncture, i.e. going in and getting that clot out. And if you then got to arrange for an ambulance to take them into London, into another trusts area, that's the other issue, whereas the helicopters tend to not have those geographical boundaries quite so much. So for speed, in some cases they actually use the air ambulance to transfer patients to London. And it is an issue, and it did impact on us if we were having to move our patients from quite a rural area to only one of our 2 hospitals that could thrombolyze prior to telemedicine. That made a really big difference. And with the 3 hours, and they had to be under 80, all those kind of additional conditions made it less likely for us to thrombolyze. So being able to move the doctor virtually rather than the patient physically is actually a really good way around it. And also we know moving critically ill patients is not a good idea. We know that does impact on their clinical outcomes. There's a lot of evidence around that. So for us, particularly that rural geography has made a difference, and we've been able to use the technology to kind of meet that need, particularly in terms of we're not having enough stroke consultants available 24/7 at some of these other hospitals. We can actually use these limited resources much more easily.
And it is a new way of doing things. So bringing the stroke consultant to the patient who might be in a different location, in a different hospital, virtually makes sense. But I wonder how stroke consultants have felt about that, because it is different, I guess. So, they need an assessment as to whether this is a stroke or not. And that's very different doing that perhaps through video technology rather than doing it if the patient's there in front of you. So have they found that is safe? And have you had any resistance from them, or any stroke consultants who actually say, this can't work because it's not safe?
We haven't actually. We've been really fortunate. I think whenever you're setting up anything like this, it's really important to get senior clinical engagement. And I think we were very much pushing against an open door in that sense. We knew that not everywhere could meet their 24-hour cover. I think we estimated that each hospital would have to hire an additional 3 or 4 consultants to be able to provide the 24-hour cover, and we're lacking stroke consultants anyway. And I think as you probably know, as a GP, doing a video consultation is very different from that face-to-face. But what we're really, really lucky is that we have some excellent stroke specialist nurses, and these people are key to our system working. So we put in some additional education for these stroke nurses and the junior doctors in A&E, and nurses, and the A&E doctors as well. And what we focuses on is not necessarily how to use the technology, because that's really not that important. What's important is that your patient is assessed properly, that you understand why you're referring that patient. So we developed a very simple, colourful pathway that's really easy to follow at 3 a.m. when you've only got 15 minutes left to thrombolyze somebody. So working through, so we want blood pressures done, we want blood sugars done, we want any mimics ruled out, we want to know when the last dose of their anticoagulant was, what their blood pressure, are their bloods done, is there an ECG done? So we're expecting them to do all of that before they refer the patient, so that we get the most appropriate patients. So these clinical nurse specialists are really key, and have done additional education and training, and work very closely with the stroke consultants, who are the ones that are on the rota as well. So they're often speaking to their own stroke consultants at 3 a.m. because they happen to be on call that night. So we've got a very collegiate group of people, which is why I talk about a partnership rather than a service, because it is about sharing education and skills. And certainly they've learnt, I guess, the kind of the techniques that help in terms of video consultation. So I've got a screen behind me today. I mean, we usually chat with lots of books, but that can be quite distracting if you're trying to talk to a patient who is, going through a really, intense emotional period in their life. They want to be able to see and hear clearly that stroke consultant. And key for us is that the patient is at the centre of that. So the doctor has not only that clinical information from the local stroke team, but they've also seen the CT scan, and we send our CT scans through a system so that they're available for the stroke consultant, so that they get really good clinical information to be able to make the clinical decision with the patient and with the local stroke team about whether that patient is thrombolizable or not. And then we go through the consent and the risks with the patient, and we come to a joint decision. So that conversation happening virtually, and I think that because the local stroke teams are so good at that now, I think it's almost, they don't think twice about it. It's almost implicit in their practice. And I think they very quickly get over this, hate seeing yourself on screen, because nobody likes that. But you can, the thing with Visionable is you can put that in the corner and make it really small, which is what I do, because I don't like seeing myself on screen, as most people don't. And also preparing the patient for that as well, because themselves being on screen, we had one particular patient who had quite a dense sort of facial hemiplegia, and she hadn't seen herself in the mirror. She wouldn't have done necessarily, and they didn't. So we get verbal consent, we're going to talk to a stroke consultant, they're going to be available on the screen. And she got really distressed because she hadn't seen her face. And so these are the sorts of things that we learn from, and we feed back to the stroke nurses. So when we're talking about when we refer, we're just saying, just remind them that they're going to be on screen and their face looks slightly different. And those are the little things that just help to make the consultation easier for everybody, and everybody introduces themselves. I'm Dr. whoever, I'm the stroke consultant, and the stroke consultants are at home, and they're home based. They may be actually on the ward depending on what time we speak to them. So their confidentiality issues aren't so much at home, because obviously they're not in a clinical area. But we have a speakerphone system on the cart. And again, as a nurse, that's something I wasn't really comfortable with, but we can offer the option that they can speak to the patient, or the doctor can speak to the patient over the mobile phone if they feel they don't want to say anything out loud. So that's useful. And we have a text messaging option in Visionable as well to share any confidential information. So we've tried to meet the needs of getting that key clinical information as quickly as we can, as accurately as we can, to help make the decision, and doing that all within the video consultation. They've all become very skilled at that. And when we have new doctors joining the rota, we buddy them up with another stroke consultant, just to ensure that they kind of recognize that these are it's a different way of consulting. And since COVID, I think everybody's probably more comfortable with that, particularly the patients. Again, I don't know whether you've seen that with some of your patients. There's more of an acceptance, I think, isn't there, of video consultations now?
And I think even, amongst clinicians and amongst patients, people who were perhaps very skeptical about video consultations a year ago we've come around because we've experienced it, and
Yeah.
I guess we've all been amazed by actually what you can do by video consultation.
Yeah.
How quickly could you bring the consultant to the patient? I'm thinking about if an ambulance is called for what may or may not be a stroke. We know in a lot of cases that there are things that can mimic a stroke.
That's right.
Can a consultant be brought to the patient's home? And are there ever any cases where then that means the patient is saved from that trip to hospital if it's not necessary?
Yeah, and in fact, we've been doing, so we did a feasibility study looking at just that. And we know that, 40 to 50% of suspected strokes are actually stroke mimics. And they're often mini strokes or transient ischemic attacks or migraines are a common mimic as well. So we did a feasibility study with Ipswich Hospital and our local ambulance trust. And we provided the paramedics, so they had an additional education session on understanding and recognising stroke mimics. So we provided them, I think they had an iPad and an iPhone. So there were 12 paramedics in total. We gave 6 an iPad and 6 an iPhone just to see, how big did the screen need to be. And when they were called to a suspected stroke mimic patient, what they could do is then phone the consultant to say, I've got a patient here. And then they would join them in the virtual consulting room, and we would bring the stroke consultant into the patient's home. I mean, how fantastic is that? So it meant that we could make that decision there and then about, could we avoid taking this patient to hospital? Because most patients, don't want to go to hospital if they don't need to. If they're presenting with a mini stroke, sometimes those symptoms have resolved by the time the ambulance has got there. So again, the stroke consultant being able to take that really detailed history from the paramedics, which they're excellent at, and then with the stroke consultant being able to actually watch and view the patient, and this, what we talk about eyes on, being able to see the patient and being able to observe them. So our paramedics were able to leave those patients safely at home. So they had an ability to within the trust, they have autonomy to leave the patients at home and not convey them to hospital. But the patients were then followed up later in the TIA clinic, sometimes later that day or the following day whenever was safe. Or if the patient was a mimic, they were referred to the neurologist or to the GP for follow-up. So we did a fairly small feasibility study, and we had 15 patients, and only one patient was actually admitted to A&E. Actually had an underlying chest infection, so needed admission for that more than anything. And the patients would be able to remain at home. And we asked the patients what they thought of the service, and we thought they'd talk about, it was really good to have the iPads, and we could talk to the stroke consultant. So they liked that, but what they really talked about that stood out for me was the professionalism and the practice of the paramedic and the stroke consultant. So the technology didn't really matter, and this was, before COVID. It was actually how good the paramedics were at assessing them and how confident they felt in their skills. So I thought, actually, that's the really important bit, isn't it? It's about the patients feeling comfortable and the practitioners being competent, and that comes back to education and training, doesn't it, to ensure that they're able to safely examine the patient. If the patient became unwell or any problems, they would, immediately we were told to call them back. So we had lots of safety netting in place. But I think if you look at that as doing for stroke mimics, what else could we use it for? There's all sorts of things that we could think about where patients could remain at home and not be conveyed to hospital. And we had an interesting discussion last night about other, sort of more urgent care issues where maybe we could, call in an expert to, I've got a patient with a wound I need somebody to look at, or I've got a patient with, sort of non-cardiac chest pain. I don't think they're acute, but I need to talk to somebody. Who can I talk to? So it's just having the eyes on, which is more than the telephone call, isn't it? Being able to observe the patient clinically with that expert eye. So that's really, really interesting. We're about to roll that out across the region. So with 2 of our hospitals, we're going to link with the stroke consultant. And in one particular hospital, the stroke nurses assess the stroke mimics as they come in normally. So we're going to link with the stroke nurses. So we're going to have a look at the 2 and see what the outcomes are. So it's going to be really interesting once we get that up and running.
And it potentially loops back into what we were just talking about. We've got this 4.5 hour window, and there's still a lot of work needs to be done in ensuring that people call for an ambulance immediately if there's anything that could be a stroke. And I guess, talking about that side of the service, that, it doesn't necessarily mean that a paramedic is going to come whip you in an ambulance and take you an hour to what it might be, I guess, to the nearest hospital sometimes. It means that we have this additional resource where the doctor, whether it's a stroke or maybe it's a cardiologist, if it's a chest pain type situation, they can assess you. So if you're thinking as a patient, I don't think this is anything to worry about, but my mouth has started drooping and I know that could be a sign, but I feel fine. Those patients may be hanging on, waiting to see if it gets better, when really we want them to call 999 straight away and get assessed. So it could link back into giving people confidence to seek help sooner rather than later.
Yeah, absolutely. We know that everything, isn't it? But prevention is better than treatment at the end of the day if we can get in and treat them. And the other bit that came out of this was quite interesting, was from the paramedics' point of view, because one of the things that paramedics will all say to you is they don't really know what happens to the patient once they've taken them to A&E and dropped them off, they've handed over, and they go to the next case. So, actual fact, a couple of the paramedics actually took a real interest in this, because obviously they knew what was happening with the patients, they got feedback, and a couple of them actually joined the ward rounds in the hospital and actually spent some time with the stroke consultants, and they were really interested in, there was a couple in particular really interested in stroke and wanted to know much more about it. And the consultants were brilliant. They said, yeah, come along, come and spend some time on the wards and you can see what we do, because they obviously only see a very small part of the stroke pathway, and there's much more to it than that. So that was really interesting outcome. So we kind of were able to set that up for them, and that ongoing education and the feedback to staff, particularly during COVID, because there's been, as he says, lots of non-clinical emergency drivers out there helping with these ambulance service, and their default position will be obviously to take the patient into hospital, but actually for a number of those people who are helping, which is amazing, they're the ones that need the clinical support. And it may be to an advanced paramedic sitting at a clinical decision desk. It doesn't necessarily have to be to anybody in a hospital. It might be somebody within their own organisation, but it's just having that kind of, what do you think? I'm not really sure. And we were talking to a paramedic last night, and he said that he went to a patient and they weren't particularly unwell, but he just felt there was something wrong. And when he spoke to a clinician, they said, well, they're septic. You need to get them into hospital. At least it was just, I couldn't quite put my finger on it, but I knew I needed to speak to somebody. And that was a really good example of, oh yeah, okay, yeah, I didn't. And he said, you've done a long shift and maybe you're tired and you're not really on your game. And you just know there's something, that kind of almost intuitive gut feeling, this patient isn't quite right. So it's that sort of thing, isn't it? Somebody else coming in the background and just having a view of that patient and helping with decision making.
It sounds quite futuristic in a way, doesn't it? Almost if you're a paramedic or an ambulance driver and you have the patient, you've done your initial assessment, and then you just patch in, you go to control room and you patch in the correct doctor, whether that is a stroke consultant or whether it's a specialist nurse or whether it's a cardiologist or maybe it's an A&E doctor who says, actually, do you know what, this wound, I think some Steri-Strip, good clean and Steri-Strips is fine. We don't need you to bring them in. It's future. There's lots of benefits to it, but it's not the future, because it's happening.
It's now. And actually we were talking the other day, it's not really about the technology, it's building up those networks, isn't it? It's finding out who those people are, and more often than not, it's actually they're more than happy to see those patients now, because actually not only does it benefit the patient, but it helps you just plan a little bit, doesn't it? It's, well, I can actually, if you do this now, I can actually see the patient in a couple of days in the clinic, and let's see how we get on, perhaps start some antibiotics or perhaps put some Steri-Strips on and let's follow them up. And that actually makes much more sense to the patient. And you just leave telemedicine or whatever, it's like, it's an enabler really, isn't it? It just enables you to deliver that care. It might not be your area of specialty, but it doesn't really matter, because you can phone a friend. It's that kind of bringing somebody in.
And I think we've seen paramedics in particular be put under huge amounts of pressure this past year. And I think we have this 4.5 hour time, the gold standard of care, if they're appropriate for it, being thrombolyzed. How much do you think the actual ambulance drive bit, how much of that makes a difference? Because you are particularly if you're in a rural area. I know we always learn at medical school, you know, if you're going to have a stroke, you want to do it between 9 and 5 Monday to Friday.
Yeah.
Largely because that means that there will be a stroke consultant in the hospital. You'll be able to get a CT scan. It's fully staffed. The right people are there to give you the right treatment. And I guess until now, without utilising this type of technology, if there's a lack of stroke consultants, and every hospital would need 3 more stroke consultants to be able to provide around the clock care, it just hasn't been available. And this is filling that gap. But what about the actual ambulance journey, or that drive? How much of an impact does that make?
So we've been able to shorten the drive. So obviously they're taking them to their local hospital instead of the hospital much further down the road. And our paramedics have become in recent years recognised professionals, and they're now undergo a university education, which they hadn't done many years ago. So that their clinical guidelines that they now deliver are much better. You know, in sort of 30-40 years ago, they were transport drivers really, whereas now they do a lot of care in the back of the ambulance, and they're able to recognise lots of these, and able to deliver medications to bring down somebody's blood pressure, can administer glucose if the patient's glucose is low. And it's about also, I think, they can alert the staff much earlier on that they've got somebody in the back of the ambulance. So that normally what happens, certainly in our area, is the paramedics will ring and say, we're 20 minutes out. We've got someone who's, fast positive, i.e. they've got some of these symptoms, their blood pressure's high, we're reducing that, we're on our way in. So they alert the staff much earlier. So that stroke nurse, and this happens out of hours as well as in hours, is ready to meet the patient when they hit the door. So it's almost though that care has started before the patient arrives to hospital. So whilst we can set these telemedicine systems up, unless we've got that care in the background, unless they can get thrombolyzed at that hospital, or they can get admitted to that hyperacute stroke unit and have that CT within 60 minutes, as the guidelines recommend, there's no point in telemedicine. So it always comes back to the people rather than the technology. But if we can, it adds more to that in terms of if that paramedic's got a wearable camera on, and you can actually see and speak to that patient on the way in, which is maybe the next bit of this, then we've got more of that information ready, and the patient's going directly to CT. We're not having them necessarily stop to do some additional things in A&E. We can get that CT done slightly sooner, so that we can then speed up that the patient, yes, they've definitely got a blood clot, it's an ischemic stroke, we can thrombolyze, or we can thrombolyze, they're actually having a really big stroke, they actually need to be going to the thrombectomy centre once we've thrombolyzed them. So I think, there's more that we can do. Certainly there's the development within the pre-hospital, and we've got advanced paramedics, we've got critical care paramedics who were able to add additional care. So we were we're doing a stroke podcast. It's one of the things we're looking at to support the education. And I listened to a HEMS podcast about cardiac care the other day, and it was really interesting because they were talking about using their air ambulance, not just for the things we think, big accidents and lots of people involved, but actually they can add care to lots of things. And that might be additional analgesia, painkillers if somebody's got a nasty fracture, but actually just bringing in that kind of mobile intensive care unit to that patient where they need it. One of the questions, or one of the queries was, but isn't it expensive? Air ambulance charities. And they were saying, well, it costs X amount a day to run the service, to have that helicopter sitting there, whether we use it or not. So actually, it's better to use it than leave it sitting there all day. And lots of paramedics don't use it because they're frightened to call. And they said, but if you're having someone with a really big stroke, we might be able to fly them directly to Charing Cross or London to get treatment. So do call us early. So I think we're beginning to see that development of our paramedic pre-hospital practitioner colleagues, and then with the overlay of using technology to support them even further to deliver their range of drugs that they can deliver. They have an enormous range of drugs and medications that's available to them, which is amazing, and also the monitoring equipment. If we can feed some of that back in and share that with our hospital colleagues, we can start that care before they even arrive at hospital, which would be fantastic.
Well, I think I've got 2 more questions for you, Lynda, and then we'll see if there are any questions from people watching. So people watching, if you do have any questions for Lynda about this, it's really fascinating, then please do pop them in the chat. We've kind of just started touching upon cost of using an air ambulance.
Yes.
In the NHS, public sector, it's all about cost and cost savings. And, it's clear with this service that you're using now in the East of England, which means that whatever time of day or whatever day of the week you have your stroke, you now have a good chance of receiving the gold standard of treatment, whereas before that perhaps wasn't the case. So even if it is very expensive, it's worth it. But what is the additional cost associated with running the service in this way?
So at the moment, we're just to explain a little bit how we're organised and actually set up. So we're hosted by Addenbrooke's Hospital, although they don't use our service because they have luxury of 24/7. We say luxury, it should be standard, shouldn't it? But 24/7 stroke consultants, because they're a regional neurological centre.
Are they one of the two hospitals?
Yeah, so we've got Norfolk and Norwich. So we've got Norfolk and Norwich on the coast, which are a big hospital. We've got Addenbrooke's, and then Southend also is quite a big hospital as well, and is, I think, becoming, or is certainly a neurological centre. So, but there's quite a lot of, if you look on a map, there's long travel times in between them. So we charge, I think we're doing, it's always about budgets, isn't it? And I think the service is roughly, if memory serves me correctly, is about £75,000 a year, and that provides you with a managed service for your out of hours stroke care. And on the flip side,
£75,000 for the whole hospital.
Yes, for stroke.
Wow.
And on the flip side of that, our recent health economic analysis by the UEA said that we saved each hospital trust about £450,000 a year with ongoing costs. So we are a cost-effective service. It's not a lot of money when we're talking about the vast sums that are spent. And we know I think stroke care is about 8.6 billion a year annually for the NHS. That's an awful lot of money. So this is a small amount of money, but we can use it to support same system to support our paramedics. We're also doing a project at the moment to look at assessing those patients who are not urgent and not thrombolizable, but need assessing by a stroke consultant within 14 hours. So we're doing a little virtual stroke clinic in the evening at one hospital to see how that works. So it's a very flexible tool that I think people now understand much more. So it's a very cost-effective service from that point of view, and that employs me as a full-time person, and I generally spend my life nagging people to do things and organising bits and pieces. We have a technical manager, and it's really important to have a technical person to liaise with the IT departments, and then I have someone to manage my rota, and that's it really. We're very small and beautifully packaged, but we're quite an effective team in terms of keeping it running. But again, the stars of the show again are our stroke nurses, who are the ones that run the service, and at each hospital I have a lead stroke nurse, and they're there anyway, so they're there to support, and we have meet up with them and find out what's going on. And we're going to be setting up regional meetings with them, and also with our 7 hospitals as well, to look at how we can improve things. That's something we're starting shortly as we're moving towards these integrated stroke delivery networks. That's really important. So it's utilising the skill set we have, and then adding in a bit of technology to kind of link it all together and bring it all together, really. That's the secret, I think.
I think you compare that cost to what it would cost for 3 additional stroke consultants, which just wouldn't be affordable, but this really is, and saves lots of money. So cost effectiveness, big tick. Final question is about the people who've been working, so the stroke consultants, the nurses, the junior doctors, the paramedics, and the patients. What has the overall feedback been from people who've been working in or who've benefited from this new way of doing things?
Certainly, it's been very positive. So we talked about the feedback from the paramedic stroke mimic study that we did. We haven't done a formal feedback of our patients, but we have one. We did a video with one of our patients, the first patient. I think it was thrombolyzed at Watford Hospital, and she was in hospital for 2 days. She could get home to her granddaughters. She was just over the moon about how good the service was, and about how this lovely handsome doctor saw her. It's a lovely video, saw her on the screen, and he came to me, the stroke doctor came to me, and they said, she explained how they told her it was a new service. So we've had very positive feedback from the patients, and I think they like the fact that there's an expert there that's brought there when it's needed. There doesn't seem we haven't had anyone complain or refuse. Certainly the no feedback that I'm heard from, and it also supports the ongoing, patients learn something a bit about it, and because they understand the care a little bit more and the urgency for that. And I think they appreciate the sense that this has been set up to make sure we can give them the best care, the gold standard, if you like. And it's also really useful whenever we do run a masterclass at the hospitals. It's amazing how many of the doctors kind of stop, can I just come in and just sit in? You gradually find them sort of joining you. So I think they find that education element, because we focus very much on who you should refer rather than the telemedicine bit. And they always say when we do the telemedicine bit, is that it? Because it's literally, you just click here and it's 2 clicks. That's all you need to worry about, which is really good.
Which is what we want as doctors.
Well, you don't want it. You just want it really. We're not, absolutely, and most people aren't, and they want it really simple. So I think they're quite surprised when Kayvan, who's my clinical lead, my education lead, will sit down and go, let's just review the anatomy and physiology. Oh God, yeah, that'd be really, really helpful. And let's go through some cases. Right, what do you think about this patient? So we really get them thinking about the assessment. We go through the pathway with them, and it makes sense. They're used to it at their hospital. So I think there's okay, that fits in with what we're doing. Yeah, we understand. And it's like, if you're an A&E and you want a consult, could you just pop into this cubicle? We're just doing that virtually. And I think we're very fortunate that our nursing group is very stable. We have very low attrition rates, so they've been there for a long time. They're better at this than I am. I mean, I'm rubbish at it, but yeah, absolutely. And we've got some really lovely nurses out there, and they're the ones I go to. And they're the ones sometimes when we get the registrars who are really keen to do stuff, and the nurses in the background are going, "No, it's not for you." No, we're going to phone. It's like, no, it's not someone I'd refer. And you find that actually the registrars will defer to the stroke nurses because they're the ones with the knowledge and experience, and they'll say, "Yeah, no, this is, if you have a look at our pathway, actually, we wouldn't thrombolize this patient. It isn't the best treatment for them for a range of reasons." So there's, I think, a general acceptance, and we have a very good working relationship with the clinical team, which is really important. And I think having, as a nurse practitioner, I worked with telemedicine many years ago. So I think having a degree of credibility helps as well, that you're not just some dumb broad that comes along and says, "I think this is a really good idea." You can say, this works, this will be good.
Well, I guess that's one thing every service like this needs as well. Every service needs a Lynda, because you're the glue, aren't you? You hold it all together.
Yeah, so. I try my best, but I think you need. I think it's really important whenever we speak to people who say, something cross region, what would you recommend? I said, you need somebody like me. I don't need me, but you need somebody dedicated, because I've seen lots of things set up and it's piecemeal. Unless you've got somebody dedicated to this for the most of their time, it just won't happen. You need somebody on top of it in terms of contracts and payments and commissioning and all the little things that need to get sorted out. You need someone dedicated, otherwise things just fall through the cracks otherwise.
Yeah, it's important. I think we must never forget that without that person, these things just don't work. Lynda, thank you so
You're
much.
Welcome.
So basically,
we've got some questions.
In summary, I don't think we have any further questions, so we can wrap up. But in summary, I guess what I've learned from talking to you about this is that this is a new way of utilising technology that improves outcomes magnificently.
Yeah.
It saves money, and doctors and nurses and paramedics and other healthcare professionals working in it are happy and satisfied and having a better experience. So it's win-win-win all round, I guess. And we haven't had any further questions that have come in live. There might be some questions that come up afterwards, so perhaps we can answer those in the chat on LinkedIn. But otherwise, just to say a huge thank you for sharing all of that with us.
Oh no, that's good, and it's great to talk to you and catch up. So it's really useful, and thank you everyone for listening in.
And I guess final thing to say is, if anybody did want to watch the webinar that Lynda did earlier today, then that will be made available on Visionable's social media platforms, or just drop a message to Visionable on LinkedIn, and we can send a link. So great.
And they should have my email address. If anybody wants any more specific information, then please feel welcome to contact me, and happy to share our experience.
Brilliant. All right, great. Well, enjoy the rest of your afternoon.
And you. No, I've got rain. It started to rain here. We've swapped weather. Lovely to talk to you. Take care.
Bye-bye.
See you. Bye.